without further ado, Dr. Brendan Lear earned his doctorate from the Department of Philosophy at the University of Alberta in 2002. Dr. Lear is a clinical ethicist who has served for many, many years at the University of Alberta, Stoller Children's Hospital, Mazankowski Alberta Heart Institute. He is an adjunct professor with the John Doster Health Ethics Center. He has diverse research interests, including topics such as pediatric best interest, moral distress, end-of-life decision-making, transplant ethics, ethics of medical technology, and compassion in practice of medicine. On a more personal note, Dr. Brendan Lear has been a longtime mentor and teacher for countless of individuals in the Edmonton zone and beyond. I know I look at him as a mentor since I came into practice, and have been absolutely privileged to have been able to work with him over the years and to learn from him. So to have him speak today is a true treat. He's been kind enough to put up a poster to remind people about our upcoming Rural and Remote Health Ethics Symposium on November 28th. But at this point, I know I'd like to do nothing more than to hear him speak on today's topic. So I pass it over to you, Brendan. Thank you.
Wow, what a kind introduction. Can you hear me okay?
Perfect.
So thank you. Thanks to all the people who've showed up today. I know you all have busy lives, and it's a great pleasure to see you. I have to take a give a special shout out to Gary Goldsand, my own teacher, my own clinical ethics mentor. I see is tuned in, so thanks for that. It's nice to see you. Nice to see your name anyway. This discussion today is going to be if you come here to see an overview of the sort of detailed overview of the coming MAID criteria, then this is the wrong talk for you. This is not a good general overview, although there are many of those available. This talk today is going to be questioning the new criteria and examining the new criteria from the perspective of bedside clinicians, from the perspective of doctors, nurses, both who are work inside of MAID and in the provision of MAID, and those who come from without. I am going to take a very short time at the beginning to go over what the criteria are going to look like as of 2021. There has been a moratorium on the inclusion of mental health or of persons who have mental health primary diagnoses to be candidates for MAID until March 2024. So in 4 months, I guess. Has been a lot of increased anxiety and concern, and a lot of discussion in particular, particularly in the media about what this is going to look like, and a lot of concern from being expressed from health authorities and clinicians in general, that they are, now that they see this coming, are not particularly comfortable with having the capacity to deal with these new criteria. So the new criteria basically changed for the old in response to a court decision in Quebec that basically argued that the criteria of the reasonable foreseeability of death was unconstitutional. The federal government, in response to that, suggested that the new criteria should include people with mental health primary diagnoses, but there was some controversy surrounding this. So we'll be sort of diving right into this. And there's one more thing that I would mention. So there's kind of two tracks for MAID now that have been identified by the federal government. This comes right out of their documentation. The first refers to procedural safeguards, made people who have natural deaths that are foreseeable. And then track two, this is an interesting terminology, refers to procedural safeguards applicable to a request for MAID made by a person whose natural death is not reasonably foreseeable. So you have two tracks, and allow me to paraphrase here in a way that might be clear. One for people who are dying, and one a second for people who are not dying, that the government seems to prefer to have given this other name. So this was the challenge in Quebec that that the federal government in the legislation has named as the absolute necessity for changing the legislation to include not dying people. This is not was particularly controversial though, and stimulated a response from law professors across the country. So there were about 30, I think, that eventually signed this. And the claim by these law professors was that the interpretation of the Truchon was absolutely did not necessitate the inclusion of MAID for mental illness. And they seemed to take great offense. This letter is very coherent, and this is its own sort of debate in and of itself. I won't discuss it any more than that, apart from to say that the federal government has clearly not addressed any of these concerns, but is still sort of stalwart in the inclusion of MAID for mental health. And a couple of different, and it's stalwart to the extent that even very seasoned politicians, a couple that I've talked to, say the insistence on the inclusion is pretty remarkable in the parliamentary process, in the political process. So they posit other reasons for this inclusion that I won't even speculate about. Not concerned about it, speculating about. What I'm going to do today. What I'm going to do today is actually something different than I usually do in my talks. I'm actually going to read a large body of text in this talk, not off slides, but read it as they wrote it, because I wanted to be incredibly careful and make my case and carefully describe my perspective and my argument. So I know I don't have an interesting voice. So if you find yourself falling asleep and smashing your head, I apologize. Maybe drink some coffee or prop up your head with one of the airplane pillows. So I reluctantly begin this presentation with a short biographical sketch, simply to explain my personal interest in the topic of euthanasia in general and its current application in the healthcare in the form of MAID. In the early 2000s, it was my pleasure to begin teaching ethics to undergraduate health professionals. Wherever possible, my course material would include the James Rachel Classic, New England Journal of Medicine article, Active and Passive Euthanasia, still an excellent read and a clinical primer, where Rachel's attempts to tease out the claim at the time that there was a moral difference between killing and letting die. I subsequently trained and began to work as a clinical ethicist, 2006, a period of historic change in Canadian healthcare. It was an incredibly rewarding time, and my intellectual curiosity about the realities of medicine and nursing could instantly be satiated by one of hundreds of willing interlocutors happy to share their candid thoughts, opinions about life, health, sickness, and death. Sadly, one of my most important teachers was not a professional, but my friend Lynn Harries, who was diagnosed at the age of 50 with head and neck cancer. She survived 2 very aggressive resections from the exceptional ENT staff at my own hospital, but to no avail. And in her final days, Lynn weighed less than 100 pounds and could not even manage to drink a bottle of Ensure in an entire day. The timing of her disease and death was coincidental with the legislation of the legalization of MAID, and I was happy to facilitate the family's process for her. At no time did I question her judgment or my participation in the execution of this simple task. Lynn's illness has always represented in my mind the canonical example of a reasonable request for the delivery from suffering for someone who could not help herself. I remain inspired to continue to think and to write about MAID, despite it being paradoxical, unsatisfying, and certainly an unrewarding exercise. I mentioned to Cheryl Mack, who is my close colleague and collaborator, that this is a very unusual, that writing about MAID and euthanasia is very unusual in healthcare, because we consider ourselves to be hold a middle ground position. And it's usually the middle ground is the easiest ground to hold in any kind of philosophical debate. and in MAID, it's paradoxically the hardest ground to hold, and has been personally, intellectually, quite costly to hold. So why do it then is the question. Well, responsibility is the first reason. For 20 years, I've had an unparalleled, epistemically privileged perspective. Clinical ethicists exist in healthcare, immersed in these wonderfully elaborate hierarchical structures, but don't appear in those structures. So people who typically would never share their candid opinions with anyone else inside of the structure, higher or lower, would share them with me, and that perspective was just absolutely remarkable. So I've discussed MAID with every stakeholder, bar none, from dying requesters, patients, to nurse and physician providers, to technocratic administrators, lawyers, politicians. I consider sharing this opinion both a personal responsibility, but more so simple reciprocity and gratitude. So to give my thanks for people who've taken the time to share 5 minutes or 5 hours or 5 months with me discussing these things. My second motivation, for lack of a better term, is basically love. It's certainly not self-love, but rather the love I feel reflecting on the decades I was privileged to witness the firsthand struggles and challenges of clinical staff working at the bedside in healthcare. The health professions themselves are elegant and ancient machines. They continue to function effectively as moral compasses in a world much different than that of their creation. Fact that they function so well, that criticisms of professionals who refuse to provide MAID ultimately reduce to criticisms of the professions themselves and of their covenantal status with society. So I've just flashed up a couple pictures of the Antikythera mechanism, which is this wonderful mechanism that was discovered and was incredibly elaborate creation in Hellenistic Greece, basically a very elaborate mechanical calendar that still seems far more sophisticated than we would ever predict a machine, a 2,000-year-old machine being, and yet here it is. And so, I think the professions are very much like that. Think about them carefully. In fact, they work so well that we really take for granted the role they play in society, like a 3-legged stool. If you kick out one of the legs, you realize very quickly what role it played. However, the professions themselves are frankly terrible at advocating for themselves. And I mean, in a professional sense, nurses have unions and physicians have their own groups like the CMA and MA, but they are not good at advocating for themselves for the professions as a profession. Recently, I've been studying the traditional prohibitions about physicians treating themselves. While this rule enjoys wide agreement and compliance, the rationale is actually poorly understood and the risks are highly underestimated. So, as it turns out, there is a sort of interesting paradox that exists when we try and advocate for ourselves or understand our own best interests, even when we practice in a discipline that is a curative discipline. There is this amazing paradox about how badly physicians actually perform when they are attempting to treat themselves. And it's a marvelous puzzle. But I submit that this paradoxical phenomenon, the failure to anticipate harm to oneself, to extends the ability of clinicians to know why, how, and when to advocate for themselves, and especially, in particular, when to say no. Which, to me, if you want to boil down the role of professions, the difference between a professional structure and a consumer structure in offering services, professionals need to be able to say no, basically to fulfill their fiduciary duties to their clients. So the sort of consumer model of medicine will say the request is a value in and of itself. You can't challenge the integrity of the request. And professions say need to reserve the ability to say no to people when they ask for particular things, mainly because they think these things will be bad for them. So for many years as a graduate student, I was fortunate to study and teach environmental philosophy. I was naturally drawn to the most practical and applied elements of activism and the role of advocates within civil society. It became clear to me in the face of apparent futility of direct advocacy. In the 90s in Alberta, there was lots of this interesting stuff going on, like hanging from banners or spiking trees. So you had these people who were the government referred to as eco-terrorists, running around doing things like this, making mischief. But it became clear to me, philosophically speaking, that the purpose of that kind of rebellious action, public action, was to reorient or shift the political center of the discussion. So initially, the far edge of an environmental discussion in the 80s and 90s were people like Sierra Club and Greenpeace, who were considered to be radicals. So the idea being that to frame the rhetorical framing of a problem, of a social problem or a social debate, where the natural middle point of the debate is skewed left or right, is in itself a deliberate injustice, and especially government and media are experts at doing this, making people who have reasonable concerns look like they are far more radical than they actually intend to be or indeed are. So in my opinion, this is the status of the contemporary professional discourse on MAID. I avoid mentioning public discourse, including social media altogether, mostly because I consider it to be a cesspool that no one should have to bathe in. But instead, I refer to the discourse of government, health authorities, in particular, Canadian Bioethics Publishing. The framing of MAID policy and the arguments and justifications almost exclusively fail to consider professionals as moral stakeholders in the MAID conversation. Philosophical rigor has been replaced with ad hominem attacks on the professions, where once gaining insight about human nature justified a philosopher asking us to imagine bisecting innocent victims with trains. Now bioethicists line up to cast stones at the values of medicine as being antiquated, arrogant, entitled, and should rightfully wither when exposed to the pure light of healthcare's new god, which is autonomy. But the professions deserve justice. They deserve recognition as stakeholders in the epochal chain perspective, perspectival ethical shift, and the request of them to bear heretofore unfamiliar and taboo responsibilities. However, justice making is hardly ever actually about self-efficacy. Justice making necessitates advocating for others. And to this end, in presenting these thoughts today, I find myself inspired by a fellow Canadian who I was fortunate to meet as a young environmental philosopher. So this is a description of an interaction between Paul Watson, who was one of the founders of Greenpeace and then went on to found the Sea Shepherds. And this circumstance occurred in Japan at the mouth of a river where fishermen were entrapping and butchering pods of dolphins. And so during this discussion, a fisherman asked Watson, which is of more value, the life of a dolphin or the life of a human? And this is Watson speaking. I answered that in my opinion, the life of a dolphin was equal to the life of a human. And the fisherman then asked, well, if a Japanese fisherman and a dolphin were both caught in a net and you could save one, which one would you save? And all the fishermen in the room smirked. They had picked me for a liberal and felt confident that I would save the fisherman, thus making a mockery of my declaration that humans and dolphins are equal. Well, I looked around the room and I smiled and said, I did not come to Japan to save fishermen. I'm here to save dolphins. So I'm inspired by Watson in behalf in this talk, in that I am here speaking today on behalf of doctors, and I am speaking on behalf of nurses. I'm speaking for MAID navigators and consultants, providers, and hospital staff. This talk is inspired by their stories, their thoughts, their concerns, and their fears. My intention in this discussion is simply to provide a perspective about MAID that remains woefully neglected, specifically MAID as seen through the eyes of a bedside clinician. The failure to solicit and consider this perspective has been systematic, enduring, and striking as an oversight. However, it can be clearly appreciated when one chooses to look from legislators to Health Canada experts to provincial service providers to professional bodies to academic literature, especially Canadian. Of course, the many architects of MAID will share helpful statistics about the attitudes of Canadian physicians as to whether or not assisted dying should be available to Canadians. And indeed, a majority of physicians do feel that it should be available to dying Canadians. However, there's a disparity between the physicians who assent to this poll question and the numbers who actually provide MAID. And this disparity is a striking disparity. So for instance, in Alberta, there's approximately 12,000 physicians, give or take. The number of physicians providing MAID at any one time hovers around a roster of about 100, give or take. So to me, this gap begs a question. If physicians believe in the principle that patients should have access, why do so few provide the service? And if one of the goals of the provincial service providers, so AHS in our Alberta example, is claimed as it is to quote unquote normalize MAID in healthcare, why are the numbers of providers not increasing as the exposure of MAID increases as it occurs anecdotally throughout the system? I have never liked that word normalize. Usually the attempt to normalize things is articulated in a pejorative statement. And usually the things that are being normalized are unattractive and dysfunctional. Now, I'm not making that claim. Many leaders in AHS responsible for MAID have claimed this to be the goal. But I won't use that language anymore. There may be perfectly reasonable answers to these questions, why there's a disparity and why there's not a significant uptake through exposure. Not asking the questions themselves is unreasonable. Not thinking about why that is unreasonable. So that's the point of the discussion today. The last number of years have certainly seen a proliferation of MAID literature and discussion, but painfully little examination of the implementation of MAID and its practical impact on clinicians, whether MAID assessors, navigators, providers, or regular clinical staff. Matter of fact, I just reviewed a paper that's being published right away that was an examination of the impact on MAID of families of people who had MAID provision. And it was a wonderfully articulated picture of what an ugly, beautiful mess the whole thing is in and amongst families. And it was a really wonderful, honest portrayal that I found quite moving and really challenging and difficult. And so I think that the more honesty that is associated with these experiences, the better they become. As for the reasons for this relative silence, speculation could easily consume our remaining time. So why don't we hear more about this perspective? From a moral perspective, reasons, frankly, aren't important. They're not important to me, and I don't think they're important in general. And the reason for that is that the broad failure itself to attend to the clinical inspective is important. It stands out for something. It should say something in and of itself. It's a responsibility of the creations of legislation, of health policy, practice guidelines, and service providers from any health policy, not just MAID, to mitigate potential harms occurring from or inherent to practice itself. And this does not exist, I think, in the broader context of the implementation of MAID. I am not interested in positing intentions or conspiracy to explain this neglect. Certainly, in my opinion, the only evidence of coordinated and thoughtful planning about MAID, particularly at the highest levels, is the careful foresight to include post hoc abstention of responsibility for decisions and policies that are important enough to deserve and demand ownership. And this, here I'm looking specifically at the federal government, who has basically liberalized, attempting to liberalize MAID in a significantly different way than the original Supreme Court criteria were suggested, but we'll take zero responsibility for that. And we'll discuss that later on. They have very, very convenient scapegoats set up, including the Quebec courts and other things. So Canadians, I don't think, require proof of mens rea, of the guilty mind of politicians or bureaucrats. If policy harms, whether the source of harm is malicious intent, whether it's ignorance or bias or mere nincompoopery, when policy harms healthcare, the stewards of that policy are morally responsible. Whether they are held responsible, of course, is a different question altogether. The absence of political or professional discourse about MAID is conspicuous, but not accidental. In addressing the historic prohibition of euthanasia in medicine, the Supreme Court, in its original decision, and the federal government included a convenient but false dichotomy that described physicians and their relationship to MAID. By clearly affirming the right of any physician to refuse to perform or participate in the provision of MAID, the so-called conscientious objectors stand in stark contrast to the remaining physicians who do not oppose MAID in principle, the majority of them, and are free and clear legally to participate. Of course, this distinction is quite unsatisfactory, as the traditional source of prohibition of euthanasia in medicine is Hippocratic. It is not religious. It's not based in conscience. It is professional, not legal. In fact, the rationale for the prohibition resides still at the heart of medical ethics. The single line describing the prohibition is as follows: "Neither will I administer a poison to anyone when asked to do so, nor will I suggest such a course." Now, this passage, if you consider it carefully, is not Old Testament. It's not a Talmudic style of prohibition. It does not identify euthanasia as an evil, but rather as an incompatibility. If the telos, the Greeks thought of their essence, their reason for being as having some kind of goal or some kind of aim, that was the way they understand the essence of everything. So if the telos of a physician is that of a healer and guide, the execution of that role is fundamentally incompatible with taking a life. It's a conflict of interest. Now, I will challenge to you that the current critics of the Hippocratic tradition, and there are many, I challenge that they explain how appeals to autonomy actually resolve the conflict of interest in advocating for a patient's best interest and a patient's death simultaneously. And the answer, of course, is that autonomy does nothing in that respect. It doesn't weigh into that conflict of interest. The only thing, the only answer a perspective like that can bring is a profoundly unsatisfactory one, which is basically to simply dismiss the ethos of professionals in principle. So to say that physicians should not have internal regulatory ethical standards outside of those determined by society and the status quo, which many people actually argue. So here, what I've been trying to describe is basically in this three-legged stool of legislation and democratic values and professionals in society, a power imbalance or attempt to imbalance power between them. So I argue that the Supreme Court of Canada has ordained that, as the Supreme Court of Canada has ordained physicians to be the sole MAID providers, physicians also inherit the right and responsibility to exercise professional objection to aspects of MAID policy or delivery that challenge or undermine professional judgment, practice, or the health system in general. The ability of clinicians to share observations or concerns from the lived clinical experience of MAID from within or outside MAID teams is critical for any metric of quality or safety. However, from my perspective, bedside clinicians who observe as a bedside clinician who observed the creation and implementation of MAID services, The approach was far from professions oriented. It was very technocratic and top down. It was a superimposition on the health system rather than an integration or even a segregation. MAID was facilitated in AHS everywhere requested, so exposure to staff of the process was not controlled. It was vicarious, it was unexpected, it was anecdotal. The rationale for this strategy was not shared, nor the choice opposed to opposing reserving optimized specialized space and locations for MAID. So instead, we decided to have, instead of having specialized spaces, we chose to do it everywhere. And to hospital staff, that process was unclear, and often the provision of MAID not even shared with unit staff. I found the actual provision of MAID to be principled. I found the actual provision of MAID to be very principled and successful. And in brackets here, I have to say the staff of my MAID team that I worked with in my zone were absolutely superb. But with the impact of MAID on the practice of clinical staff or the consequences of the implementation on them were not measured or evaluated. Allow me to share a story from a medical resident. So here I'm quoting. I recall a case as a resident where a woman in her 60s with advanced cancer was admitted to hospital with acute pain, complications of her disease. As part of the attending team, we treated her acute medical ailments, and we were working on titration of her pain. She was keen to treat her symptoms and get back home to continue spending her remaining time surrounded by family, given that she had been recently told she was not eligible for further systemic cancer treatment. We spent a significant amount of time getting to know the patient and her family, including her adult children. One morning, after assessing the patient, who was in good spirits with improved pain control, our son stopped me in the hallway, visibly distraught. Through tears, he told me he was trying to accept that his mom was going to die the next morning, and he had always been supportive of her wishes, but coming to terms with her decision to pursue MAID was challenging him. I was in shock. This was the first I had heard about the patient's wish for euthanasia. I put my own disbelief aside while consoling the patient's son, reassuring him that I had witnessed firsthand he was an amazing, caring son, and it was okay to have his own reaction to her decision. I immediately went to find my attending, who was not aware of the patient's plan. When we went to the patient's room to discuss this, she was tearful, apologizing for not telling us sooner, saying she didn't want to make us feel like she was giving up on us. She explained the assessment. She explained that the assessment had occurred during this admission, and she assumed that the assessing doctor had updated us. We reassured her that she need not worry about our feelings, sharing that it had been a privilege to care for her. Our goodbye was cut short as we had to rush off to come up with a plan for her pain medication that would have to be altered to allow for her transportation home in less than 18 hours. This was so shocking to me as a learner. What area of medicine would have another physician assess our patient during an admission without leaving a note or discussing the care of the patient? How does this fit with the collaborative, patient-centered care emphasized throughout my medical education? Is this really what's best for this patient? In secrecy, hidden assessments, with a tearful patient worried to talk to their doctor about the end of their life and the intention of the MAID process. Family medicine resident in an acute care hospital service in Alberta. Now, note this perspective is not vitriolic, it's not rhetorical. It need not attribute malevolence or villainy to any person in the organization. This is a reflection of how MAID appears from inside of healthcare. St. Augustine claims of time that we exist with it, we exist with time, but we do not exist in it. We do not exist in time. So it could be said about the provision of MAID in the broader context of healthcare. MAID was created and continues to exist in an occult relationship to the health professions. What does this mean? We use the term occult from the Latin cultus, which means worship, simply to describe how and when the use of technology in this case constitutes medical or nursing practice or knowledge, simply whether a process, procedure, or intervention is medical or not. So in the term medical assistance in dying, the medical part is actually a bit of a misnomer because it has nothing to do with medicine. The practice does not come from medicine. So occult means something just other than what happens to be practiced. So the relationship of MAID to the health system is that of superimposition, not integration. MAID is superimposed on the institution of healthcare. It was not from the start intended to be integrated. And this institutional effort is clearly not served to increase familiarity or comfort with the process, and perhaps has achieved the opposite, affirming the practice's occult status by utilizing unnecessary levels of secrecy and a lack of routine process, such as team-based care and documentation. The relevant question today is, will the coming editions of MAID candidates who are not dying or lacking capacity to decide for themselves cross a threshold where professionals find MAID not simply occult, but incompatible with ethical, medical, and nursing practice? Now, I think I actually skipped by a slide at the very beginning because I failed to mention that apart from mentally ill patients becoming candidates for MAID, in the summertime, one of the other things that the government of Canada considered and is still considering was just legalized in Quebec, which was over the summer, patients are now allowed to legally request MAID inside the context of a personal directive. So basically, this will look like the main intention would cover people who are suffering from advanced dementia and who clearly long ago lost the capacity to consent for themselves. Now, this is not coming to us in Alberta, but there is absolutely no reason to believe, given the tradition of response to decisions in Quebec by the federal government, that the government will use this to leapfrog any sort of consideration of whether this is going to happen, and simply include it as de facto at some coming point. So Cheryl Mack and James Mallet and I have published articles already that have informed this talk significantly, or at least the way I conceive of it. This work is relevant to our discussion today, as each paper I reference discusses specific philosophical concern with each of the new MAID criteria. And I'll mention that this talk is going to go onto YouTube probably before the weekend, along with all the other Dossiter talks from this fall that have been really excellent, and all of the bibliographical material is going to be in the description of those talks. So in the first paper we published, we observed a disconnect between the responsibilities bestowed by the Supreme Court of Canada onto physicians as sole legal MAID providers and the actual practice of medical skills or judgment required to facilitate MAID. We argued that the Supreme Court and the federal government required of physicians in the implementation of MAID. What they required was not clinical skill or knowledge, but the trust that Canadian physicians have earned and inherited day by day and generation to generation in order to facilitate MAID. It is this disparity, the fact that MAID requires physicians, but not as physicians, that justifies the observation that MAID was and remains occult to medicine. It is a practice that physicians may participate in, but do not control. It requires skill, but not specific to medicine. As a matter of fact, most of MAID, most of the actual practical offering of MAID is nursing knowledge. And nurses actually, of course, was very, very soon included after that recognition. But not skills specific to medicine. Physicians have not established the criteria by which patients become candidates. This circumstance is further exacerbated by the emphatic inclusion of the requester's subjective qualifications of the acceptance of care. Now, what I mean by this is, and I will describe this in much more detail, is in an effort to explain the original Supreme Court criteria, the federal government chose in their legislation to include a passage that basically establishes the patient requester's ability to refuse any form of treatment that they find unsatisfactory, and that not constitute and still allow them to be candidates for MAID. which is basically a decision to say that ultimately physicians do not have control over this. So the point, the specific phrase here that I'm referring to says, the specific phrase that I'm referring to here says, having endured and a tolerable physical or psychological suffering that cannot be alleviated under the conditions the person considers acceptable. So this is supposed to be an interpretation of the Supreme Court criteria, but actually is a philosophical and value value statement that's included on top. I'll continue on. So the addition of this, the addition of this is supposed to be an interpretation of the phrase a grievous of the Supreme Court criteria, a grievous and irremediable medical condition that causes them enduring intolerable suffering. Now, of course, while noting that this legislation interpretation includes some significant enhancement vis-a-vis the creation of a value hierarchy about who the final arbiter of MAID assessment should be, I argue both that the Supreme Court and the expert panel actually both heavily side on a clinical criteria interpretation for MAID candidacy, in particular in mental health. MAID legislation, on the other hand, introduces an absolute subjective qualification, completely absent in the Supreme Court decision and the Supreme Court criteria. The subjective conditions of the person considers acceptable qualification is not an interpretation, but rather a value judgment establishing the primacy of the request over its clinical assessment. To clarify, let's use a common clinical example in psychiatry. So Tom presents with refractory depression to his psychiatrist. He tried several frontline medication, but still struggles. His psychiatrist recommends, again, that he be offered ECT, which is electroconvulsive therapy, which is the gold standard for refractory depression in psychiatry. It is also very stigmatic and quite misunderstood, and also has significant side effects. So Tom refuses again and feels ETC would be cruel and inhumane. In clinical practice, Tom's refusal, of course, would absolutely suffice. Competent patients have the right to refuse any kind of treatment. And he would continue to see, so in ordinary life, he would say no, no one would force him to do that, and he would continue to seek help as he sees fits. However, if Tom is making an application for MAID, his refusal of the clinical gold standard of his condition should not, according to the government, bias his candidacy for MAID. The safeguard of a second psychiatrist or 3 or 4 psychiatrists reevaluating him that are supposed to be safeguards for the new mental health criteria would be completely irrelevant. Any other clinical assessment would make no difference. I argue that any ambiguity existing over this interpretation as clearly exists between the opinions of the expert panel and the legislation, for instance, strips would be made providers of the critical important capacity that is the right to refuse, the right to say no to a patient. This capacity represents the very difference between professional health systems and consumer health consumption. And I will tell you that the most difficult cases I ever had as a clinical ethicist required incredible courage from clinicians to basically say no, to refuse, to say, no, we're not going to put your grandmother who is dying from advanced dementia on a ventilator, or we are not going to continue life support on this person who has ceased to have any kind of brain function. Now, the easiest thing to do for those clinicians to do would have been just to acquiesce to the request for treatment from families. It's very hard to say no. And that hardness, and the reason you want to reserve that, and the reason why it's essential to reserve it, is because these professionals are fiduciaries. They want to advocate for the interests of their patients. And sadly, the sad truth of human existence is that we want things, we pursue things that are bad for us. Now that pursuit might be might be a matter of your own personal interest and regard, but you should not have the right to demand of someone else that they provide things to you that are bad for you, in particular when those people are in ethical and legal obligations not to do so. So the two relevant conclusions from our second work, this is Cheryl and James and I, concern the important distinction between the function of patient autonomy in requests for withdrawal and refusal of medical treatment as requests for medical treatment. Our concern, so that every case that basically the canonical cases that establish respect for patient autonomy in Canada were cases where patients were being treated and had to have the right to say no, or the right to request the refusal or to refuse treatment to be honored. So our concern regards advance request for MAID in the express preference of a previous request over a patient's current best interests, as would happen in requests for in advanced directive request. This is specifically a problematic for physicians because the principle of the request is contrary. So let's say I say, if I have advanced dementia, I would request euthanasia. Typically that request, request in terms of the traditional Supreme Court criteria would involve some kind of egregious suffering. Now, it is not the case that people with advanced dementia, some have very poor advanced dementia and have significant suffering. Some have no suffering whatsoever, except their situations might be considered to be absolutely tragic from their family's perspective. They might not even know who they are, and yet they may not be suffering at all. So how do you consider, in the context of that, the request, if we meet certain criteria of disability, the request to end the life of a person who is actually not suffering, who may have a terminal illness, but not suffering significantly in any way? And this is the very issue with this is the very ethical issue in the problem of MAID requests in the context of advanced directives. It's a philosophical issue, in that you can argue that the person who requested and the person who is receiving MAID are two philosophically different people, that no criteria of human human personhood and personal identity are actually established between the two. There's no connection between the two anymore. So this is specifically problematic for physicians, because the principle of the request, I just read that. Okay, sorry. It is not inappropriate to point out that each of the new criteria to allow MAID via advanced directives and MAID to psychiatric patients, each allow MAID, the interpretation of MAID in patients, or each allow the provision of MAID in patients who fail to fulfill one of the two Supreme Court criteria, with advanced directives dismissing theoretically the criteria for suffering, and mental illness dismissing the criteria for clinical remediability, which I argue is the only relevant application of that criteria. So what kind of practical challenges will clinicians face with non-dying and incompetent patients presenting to clinicians responsible for assessing these requests for MAID? More importantly, what MAID legislation, does MAID legislation and its interpretation of the Supreme Court criteria provide clinicians with simple conceptual foundations to move forward? I feel there are two different answers depending on how we assess the weight of expert panel recommendations, the likelihood of their adoption, and the possibility of their adoption. For the record, I feel, despite there being public controversy amongst the representatives upon publication, and the questionable justification of the strict limitations placed on the expert panel, the expert panel executed its responsibilities very well and made very reasonable recommendations. Moreover, there are clear articulated suggestions about what specifically should constitute legitimate criteria for fulfilling the Supreme Court criteria of remediability. For instance, the lack of access to social services or therapeutic interventions, in the opinion of the expert panel, should not fulfill criteria of remediability or means available to relieve suffering. For the most part, the panel and the Supreme Court assumes the source of irremediability and egregious suffering to be medically definable. However, as we see in reality, and as the government and as its bureaucracies are being primed to integrate these new criteria, this is not the case. However, many bioethicists and seemingly the federal government take issue with this interpretation that these criteria need to be medically definable. The cause or the source of an individual's unbearable suffering or its reversibility from a patient autonomy focus are irrelevant. Current government ministers and even the expert panel, in a confusing initial statement, seem to suggest they recognize legitimate MAID requests as including those seeking a form of rational suicide. If we look at the actions of the federal government and its ministries as they anticipate new MAID inclusions, some significant problems emerge. If admittedly anecdotal, examples are indicative of the federal government's ministry's conception of MAID candidacy, it is clear that the criteria of irremediability extends far beyond medical conditions and well into financial and social deprivations that are easily remediable in theory, but irremediable by choice. So here we have some examples of people, not veterans, who were offered MAID, not having reasonable access to services. Here we have an example of prisoners having MAID while incarcerated because they don't have access to palliative care. Here we have MAID responses to lack of adequate housing for medically sensitive people. This Vice article suggests, or is the first to introduce this notion of eugenics as MAID being a treatment for socially vulnerable people addicted to drugs. And this is the last example that I experienced myself. I'll describe quickly because I think it's an example of how the federal government considers things broadly when they suggest that there's a relationship between them. So we've made this petition to the federal government basically to argue that dying people seem to improve their quality of life by having access to very simple and straightforward assisted psychotherapy with the use of psychedelics, particular psilocybin. And so we put a petition to the federal government and said that what we need to do is facilitate access to people who are dying, to give them the right to try these drugs, because the process put in place by the federal government was absurd. And so we put this petition forth, and the response to it was just remarkable, if not remarkably banal and unimpressive, if not sadistic. So they suggested that in order to protect dying people, they need to find drug trials to enroll in. Any of you who know, I'm sure some of you are laughing, thinking that, yeah, dying people make great candidates for drug trials, and saying that, there's no way to guarantee the safety of these dying people. So instead of treating their anxiety towards their own deaths, we should consider it's simply too dangerous, and we need to keep the status quo in place. So to conclude here, although physicians, nurses, despite both being formally prohibited by their members to participate in euthanasia, have relatively been silent about MAID as professions per se, continued participation of clinicians will ultimately determine the successfulness of this coming social experiment. However, professions ultimately do and should be the final arbiters of the scope of their own practice. My fear that the liberalization of MAID criteria might significantly reduce the ability of MAID in general, which I feel would be a terrible outcome. However, this does not mean that physicians and nurses should not feel coerced into all scenarios created by provincial service providers where occasional controversial candidates' requests are swallowed to assure the service for traditional candidates. It is a recipe for disaster, I think, but not entirely unrealistic, particularly for services who rely on nurses and nurse practitioners who are traditionally employees of technocracies, not independent contractors like physicians. I will suggest two theoretical ways forward, working with the assumption that the new criteria are both here to stay. One option, And actually, I'll only suggest one option. One option would be to would look as follows: the federal government just abandon or fail or to resuscitate Bill 339 when it's inevitably struck down next. And the suggestion might seem unusual, but in 1988, when the Supreme Court just struck down the prohibition on therapeutic abortion, none was ever replaced. And the interest of the federal government in legislating health seems to be proportionate to perceived political capital. No abortion legislation was passed by Parliament since then. So we have no abortion legislation now. And yet, it seems we have managed to create services allowing therapeutic abortion, providing them across the provinces, and the physicians are mainly in charge of this implementation and facilitate these requests, including as I write, the services that provide termination of pregnancy across the country have managed to coordinate these efforts, including the establishment of criteria that guide both the provision and the refusal of therapeutic abortion. An issue at least equally socially contentious is MAID. The ground-up approach is best, if not only if not only the means of integrating MAID into healthcare that could prioritize the values such as integration, compatibility, and fiduciary obligation, arguably much preferable than the provincial technocratic implementation of Make It Happen. And the other one, the other suggestion here, I may discuss in the Q&A, which will start right away. My point here is simply that health professionals not seek out the role of MAID providers. The Supreme Court made it possible. The very least consideration that they should provide of these professionals who work as navigators, assessors, providers, is the process and the criteria of MAID are coherent and compatible with the health system in general, particularly with the interpretation and execution of fiduciary obligations. So the question is, when should you advocate for MAID as the best interest of your patient? If you can't ask that question, then we have to reconsider things. In Canada, in living memory, we've participated in a pseudoscientific social exercise called eugenics, and consider for yourself the role of health professions in the implementation of these policies. Did the medicalization or normalization of eugenics legitimize the philosophy? The disability community espouses a brilliant mantra: nothing about us without us. And doctors and nurses would well do the same to embrace this philosophy as social, judicial, and legislative exercise regarding exercises regarding MAID that have made the opposite seemingly the rule. Now, I'm going to end it there and open it up. I have time. I'm sorry to have pushed us to time, but I do have time to answer questions, and I'm happy to take that time as well. For those of you who have to leave, thank you so much for joining. And I hope that was helpful or insightful, at least provocative in some way. And I hope none of you injured yourself by being lulled into unconsciousness by the monotone droning of my voice.